expert opinion, I'll try to create a story, and where the characters are all imaginary, but the cases and the images that you see are all real. And through the story, I'll try and walk you through the pathophysiology and some of the management aspects of pulmonary hemorrhage. And hopefully we can have a good amount of time at the end for discussion on the topics that I've covered, also on some of the topics that I may have failed to cover in this talk. So let's dive into our story. Meet Dr. Richard Christian Thomas, or lovingly we call him Dr. RCT. He's a newly recruited neonatologist at a level 3 NICU, and he has been indoctrinated in the concept of practicing evidence-based medicine. So he generally tries to refrain from any practice that is not proven through rigorous randomized controlled trials. And today he's taking over the care of our patient, who's a 25-weeker, born by emergency C-section due to abnormal UA Dopplers. The baby is small. Birth weight was 570 grams, so small for gestation age. Was intubated fairly soon after birth, and then within an hour, due to increased oxygen requirements, up to 35%, got a dose of surfactant, to which the baby seemed to respond well. And that's where Dr. RCT takes over the care for the next 24 hours. Now, the call has been going well. The baby has been generally advertised to be fairly stable until around 18 hours of age. When the nurses start coming to him saying that, I don't like what's going on in the last few hours. The oxygen requirements have started to go up to about 35–40%. The baby seems to be a bit more unstable. The nurse reports softer systolic and diastolic blood pressure trends, but they are not too worried because the mean blood pressure was normal. Now, Dr. RCT has been trained well. He knows that never to ignore the concerns of a nurse who is upset about their baby in their shift. So he does his due diligence. The blood pressure was soft, comments were up. So he thinks that I don't want to miss anything weird and wonderful. And since there is some cardiology help, why don't I rule out a congenital heart disease? So in comes Dr. Emma Beth Moore, or Dr. EBM. So she is a pediatric cardiologist.
Recording in progress.
And he's been convinced that PDA treatment is bad for babies. And PDA is a non-entity and we shouldn't be even looking at it. He was more so convinced by this recent AAP guidance that actually kind of talks about the exact same thing. Early treatment is not recommended. Look at conservative management, which convinces him that I should probably start ignoring PDAs in small babies. So back to our baby. He chooses to conveniently ignore the duct, does a lung ultrasound just to make sure that there is nothing else going on, not a pneumothorax, finds this, and convinces himself to give a second dose of surfactant. And boom, in a couple of hours, the baby has a massive pulmonary hemorrhage. And now the baby is in real trouble. The oxygenation index is up to 21. The baby is saturating in the mid-80s on 100% oxygen and is not doing well. And Dr. RCT knows that pulmonary hemorrhage means trouble. Because if you look at this very recent study published in JAMA Pediatrics on the top 10 causes of neonatal mortality in the US in the last 2 decades, pulmonary hemorrhage stands out compared to all the rest of the top causes of death. What this essentially shows is that if you have pulmonary hemorrhage, you are at a much higher risk of dying compared to the other causes. So this is something that has to be taken very, very seriously. And the incidence of pulmonary hemorrhage is varied across the world because of different ways it is reported. If I look at one report from your neck of the woods that was published recently, that showed that among extremely preterm infants, the ones who are really small, the ones who are born less than 26 weeks, and the ones who are small for gestation age, those are the ones who are particularly at a higher risk of developing pulmonary hemorrhage. Twice as common compared to other babies who are appropriate for gestation age and who are slightly older gestation. And once you have a hemorrhage, they found that mortality and severe IVH, which are the two most highly rated outcomes among parents in terms of importance, these two outcomes were 4-fold higher in babies who develop pulmonary hemorrhage. So it is a serious problem. And mind you, our baby M is born less than 26 weeks and is slightly smaller for gestation age. So he needs to take a deep dive into what is going on, what is it, and how do we manage. So
You want this?
What is pulmonary hemorrhage and who are at risk? So essentially, if you look at the definition, it is an acute event, often presenting as pallor, respiratory failure, that is characterized by a sudden discharge of bloody, frothy secretions in the tracheal tube or up the respiratory tract. Now, one thing that we should clearly distinguish right at the outset is that what we are referring to here is alveolar hemorrhage and not tracheal hemorrhage. A lot of the times we get blood up the tube because of a trauma, because of an ET tube, with no other change in clinical signs that is labeled as pulmonary hemorrhage. And that goes into databases, and that's why we see these varied incident rates across publications. But for the purpose of our discussion today, and as we go on to discuss the pathophysiology, the associations, the management, I will be referring to alveolar hemorrhage. If you look at the literature, there's a lot of associations that are documented consistently, such as exposure to surfactant therapy, presence of a hemodynamically significant shunt, extreme prematurity, obviously, babies being small for gestation age, and higher incidence in males compared to females. And in our baby, a lot of these match. So let's look at one by one. Why did this baby bleed? Now, this baby had a hemodynamically significant PDA that Dr. RCT chose to ignore based on strong evidence. And on top of that, the baby received surfactant that further decreased the pulmonary vascular resistance. So the two combined could have contributed to pulmonary overcirculation, which was probably too much for these fragile capillaries in these very small babies, that led to epithelial dysfunction, increased permeability, and hemorrhagic pulmonary edema. So now Dr. RCT starts to beat himself up that did I end up causing the pulmonary hemorrhage? Let me look at what else could have contributed to the pulmonary hemorrhage. This baby was small for gestation age, and many of these small babies have thrombocytopenia, coagulopathy, which could worsen pulmonary hemorrhage, and also fetal growth restriction could lead to chronic hypoxia and malnutrition. And there is an association of that with myocardial dysfunction, especially LV stiffness. And if the left ventricle is stiff and is not contracting well, all the blood to back atrium, and that could lead to increased pulmonary venous congestion, and that might worsen the hemorrhagic pulmonary edema. And on top of that, if the left atrium has nowhere to decompress, that is a restricted patent foramen ovale or restricted atrial level shunt, that could further lead to worsening of that bulging left atrium, worsening of the pulmonary venous congestion, and that could only add to worsening pulmonary hemorrhage. But Dr. RCT was not really aware of these associations and therefore did not really take full advantage of Dr. EBM's expertise. So that's where maybe early echocardiography can help understand the potential risks, even though there are no randomized trials to definitely prove that it helps. One, as we already discussed, if there is a large unrestricted left-right PDA shunt, that could be a red flag and a signal for risk. We could also ask specifically for whether in the presence of a large left-right shunt, if there is a tight atrial level shunt, that would not let the left atrium decompress. And third, we could ask a little bit more about how the left ventricle is functioning, especially in the smallest babies. If you have a soft systolic blood pressure, a lot of these babies have some inherent diastolic dysfunction. So if the LV is not functioning, well, the blood backs up and may worsen the pulmonary hemorrhage. In fact, if you look at this very small but interesting study from Japan from a few years back, they looked at the stress-velocity relationship and its impact on its association, rather, on hemorrhages in extremely preterm infants. So they looked at end systolic wall stress as a surrogate for the stress-velocity relationship. And they looked at two groups, one who had pulmonary hemorrhage, IVH and PVL, and the other who did not have these hemorrhagic complications. And they found that elevated end systolic wall stress was significantly associated with the group that developed these hemorrhages. And the hypothesis was that if there is elevated end systolic wall stress, that indicates high LV afterload. So that could be associated over time with LV dysfunction. And if there's LV dysfunction, then as I just mentioned, you have increased pulmonary venous congestion that could potentially worsen pulmonary hemorrhage. So lesson learned for Dr. RCT, the next time if I'm getting help from Dr. EBM, I should, beyond just ruling out a structural heart disease, maybe I should get a little bit more information on the hemodynamics early on in these small. It might help prevent a massive pulmonary hemorrhage. But what is done is done. The question is, now what should we do? The first things first is that this baby is now the sickest baby in the unit, because as I have shown that this baby now has the highest risk of dying compared to all other causes of common causes of mortality in newborns. So what the baby needs is very careful nursing care, where you would want to ensure that the baby is monitored by pulse oximetry, blood pressure measurement, preferably arterial, making sure that the baby is intubated, well ventilated, the ET position is checked, and making sure that you have excluded any traumatic causes of bleeding. So essentially, very, very good supportive care. So once Dr. RCT is kind of ensuring that that's all taken care of, and the most experienced nurses and house staffs are stationed at the bedside, he takes a look at what other possible therapies that are available, that are evidence-based, that can help mitigate the situation. So you'll find a lot of reviews that talk about a lot of different therapies that can help in a case of massive pulmonary hemorrhage in extremely preterm infants. And there was this recent publication led by Dr. Satyan from UC Davis, who in one of his wonderful illustrations has nicely outlined the possible therapies. So let's look at the evidence on each of these therapies one by one. First, we hear a lot about tamponading, the bleeding with high mean airway pressure, switching to high-frequency oscillatory ventilation. And often at the bedside, we find people overdoing it, cranking up the mean airway pressure by 3, 4, 5, just because there is evidence written somewhere that it helps. If we actually look at the evidence, it's not that great. For one, Dr. RCT was unhappy that there were no randomized trials that really proves that either switching to high frequency oscillation or really cranking up the mean airway pressure helps. All what he found was a bunch of small sample observational studies, case reports that do suggest that yes, using high frequency oscillation and optimizing the mean airway pressure may improve survival and may improve some of the short-term oxygenation parameters. But there are no large studies to definitely rule out the downsides of overdoing it. So what most would recommend that use optimal mean airway pressure. Don't overdo it, but just use what is needed to prevent hypoxemia and acidosis. Because excess pressures may actually exacerbate the capillary leaks and worsen your pulmonary hemorrhage. It would compromise your preload. And also, in babies where there is LV dysfunction, the LV is already struggling to pump, don't make the job of the LV even harder by cranking up mean airway pressure too high. Next, the role of surfactant. So Dr. RCT is probably by now scarred by this product because this is the one that probably cascaded into this massive pulmonary hemorrhage. But once the pulmonary hemorrhage has happened, could surfactant actually help? Now, if you look at Cochrane reviews, there is actually a Cochrane review on this, but an empty one. They found no randomized trials. All what is there is, again, a bunch of observational studies, active case series, case reports, all small sample, which suggests that using surfactant with optimal PEEP may help in improving some of the short-term oxygenation measures. Now, again, in the absence of large trials, I wouldn't jump on using surfactant after every case of pulmonary hemorrhage. But in situations where the bleeding phase is stabilized, you have optimized your ventilation, and still you are in hypoxemic respiratory failure, and which could suggest that there is some sort of surfactant inactivation, use of surfactant may be beneficial in those cases. Next is endotracheal epinephrine. So now we are really talking about going gung-ho on some of these experimental therapies, maybe still bleeding and hypoxic. So if you're thinking about shoving epinephrine down the tube, sorry to say again, there are no randomized trials to support your cause. All what you're left with again is a bunch of small sample retrospective studies and case series that do suggest that in severe cases, when there is ongoing bleeding, use of epinephrine may be helpful in improving survival. But shoving down that strong vasoconstrictor down the tube comes at a cost. There could be potential risks such as vocal cord ischemia, local tissue necrosis. It could trigger arrhythmias and systemic vasoconstriction. So again, in the absence of strong evidence, I would reserve this only in cases when there is life-threatening pulmonary hemorrhage, where the bleeding is refractory. You've done everything to try and stem the bleeding, but you're stuck. You may choose to use epinephrine in those situations, but I wouldn't use that in any case of pulmonary hemorrhage. So what about blood products? Now, one could think that probably that's the easier one of the lot, but there are caveats to when you start digging deeper into the evidence. If you look at specifically use of blood products in pulmonary hemorrhage, again, the evidence is sparse. And if you look at the large randomized trials on transfusion thresholds for blood, for platelets, they specifically exclude these group of babies who are very sick and who are actively bleeding. So those big randomized trials don't really help in this situation. So we unfortunately have to go back to expert consensus. So if you look at some of the consensus statements, say from the one from the British Society of Hematology, it says that when there is active bleeding, try and maintain hemoglobin above 120. If the platelets are low, below 50, try and maintain levels above 50 and transfuse platelets. Consider FFP when there is abnormal coagulation profiles. You may consider an additional dose of vitamin K and consider cryoprecipitate to keep the fibrinogen levels above 1. So mostly common sense therapies that we employ, but just to keep in mind, none of them have really been proven through well-done clinical trials. And what about other products for coagulation support? People have tried using recombinant factor 7 and endotracheal hemocoagulase, but again, these therapies are experimental, and therefore the evidence is too uncertain to recommend them in routine practice. So while Dr. RCT was contemplating about all these therapies and trying to kind of think about what might benefit, one of the residents working with him suggested, what about inhaled nitric oxide? This baby clearly is in hypoxic respiratory failure, and I've seen nitric oxide in such situations. So why aren't you using it in this baby? And that brings us to the favorite part of my discussion today, the role of inhaled nitric oxide after pulmonary hemorrhage. Dr. RCT feels that, yeah, it's a fair point. Let me go back to the evidence. And he was finally happy to find some randomized trials with early onset respiratory failure, which was nicely summarized in this Cochrane review by Keith Barrington a few years back, where they found 10 randomized trials that enrolled just over 1,000 preterm infants. But the results, again, were a bit confusing. One, they found that overall, nitric did not improve survival, and there was no consistent evidence that suggested that nitric decreases lung injury. But none of the trials really looked at the subpopulation of babies who developed respiratory failure following pulmonary hemorrhage. So there were no subgroup analysis specific to pulmonary hemorrhage. So that's one. And the second was that he was rather surprised to stumble upon this concerning finding that there was a 20% increase in severe bleeding into the brain, severe IVH, that he never really came across in his fellowship training because this finding was not statistically significant and therefore never really talked about in his training. But this could have severe implications in this baby who's actively bleeding. And therefore, to do his due diligence, he sought to kind of look at observational studies. what does observational studies say about use of nitric in small babies? And the evidence was again quite confusing. On one hand, there are observational studies such as this one from the US, large cohort study that showed that use of inhaled nitric in early hypoxic respiratory failure had no effect on death or neurodevelopmental impairment, while there are other studies from US and Canada that showed that use of nitric following prolonged rupture of membranes, those with pulmonary hypoplasia and extremely preterm infants, may have a survival benefit. But the evidence following pulmonary hemorrhage in extremely preterm infants was almost non-existent. So that was not helpful. So again, we have to go back to the physiology. Let's look at what nitric might do to the physiology, the common physiologies that we would encounter in pulmonary hemorrhage. So as we had already discussed, that one of the common associations is a large left to right shunting duct where there is already pulmonary overcirculation. So when I give nitric here, I open up the pulmonary vessels and worsen my pulmonary overcirculation and potentially worsen the hemorrhage. So that's a problem. We also learned that a lot of these small babies have LV dysfunction, and when there is LV dysfunction, the pulmonary hemorrhage is worse. Now we have learned that when there is LV dysfunction, there is increased pulmonary venous congestion. And if I use a pulmonary vasodilator, when there is congestion of the pulmonary capillary bed, that is not going to help. So it is not surprising that when these two are associated with pulmonary hemorrhage, the likelihood that nitric will be of any benefit is low. And on top of that, can nitric really worsen the already ongoing bleeding? And there is some evidence to that. There's evidence in term infants who were exposed to nitric at 40 parts per million. It was found that in those babies, the bleeding time was twofold longer, suggesting that nitric may have an adverse effect on platelet function. And therefore, it is not surprising that if you look at the use of nitric in extremely preterm infants in large pragmatic trials, where nitric was used in early respiratory failure without looking at the physiology of the respiratory failure and the etiology, there was an increased incidence of both death as well as grade 3 or 4 IVH or PVL in those small babies who are exposed to early onset, to early inhaled nitric oxide. Because in a lot of these babies, I presume that one or more of these adverse physiologies were at play. So coming back to our baby who has had a pulmonary hemorrhage and is in active hypoxic respiratory failure, the decision to use nitric has to be carefully weighed. On one hand, you have the increased risk of bleeding into the lungs. That significantly increases your risk of dying. You have an increased risk of bleeding in the brain, as shown by the subgroup analysis of the New England Journal randomized trial, which is not a desirable outcome from a parent perspective. But on the other hand, I cannot just leave a baby who is hypoxic and saturating in the 80s on 100% oxygen. I need to do something because there is evidence that prolonged hypoxemic episodes is associated with death and adverse neurodevelopmental outcomes. So, trial evidence is clearly not helpful here. So we need to go back and examine a little bit more carefully what is going on with the physiology. And therefore, it's time to bring Dr. EBM back into the picture. And there are a couple of scenarios that could play out, and I'll just talk about the most common ones. One scenario is where you find evidence of elevated pulmonary vascular resistance. So you have this duct, which is predominantly right to left, where you could argue that, yes, nitric may be helpful, but you have a slightly dysfunctional left ventricle. Now, in that case, without a careful interrogation, nitric can actually worsen systemic perfusion because that duct may be helping with your systemic blood flow. And as Dr. RCT learned from a wise cardiologist that, yes, a pink baby is the best, but a blue baby is better than a gray baby. So if you give nitric in a baby where there is LV dysfunction, you may take away the systemic perfusion through the duct and divert it to the lungs, and therefore end up with worsening end organ perfusion and rising lactate, and make things worse. The other scenario is one that we are dealing with in our baby boy M, where there's a clear, large left-right shunting duct, where giving nitric would lower the pulmonary vascular resistance and worsen the pulmonary overflow. So in both these situations, nitric is likely a risk multiplier. But again, as I said, that we need to do something for our baby. This baby is clearly hypoxic and now even worse. The baby is now saturating less than 80% on 100% oxygen. Dr. RCT has diligently gone through what Dr. Satyan has talked about. He has gone up on his mean airway pressure to 14, transfused with red cells, plasma, platelets, given a dose of endotracheal surfactant, even a dose of endotracheal epinephrine. Went back to Dr. EBM, who had suggested that I told you that the LV was a little bit dysfunctional, so started some dobutamine to support the LV. But things aren't helping. The blood pressure is still low, 29 on 14 now. The oxygenation index is worse. So he has to bring Dr. EBM back into the picture again, who does another TNE. And we find clear evidence of elevated pulmonary vascular resistance. So there is significant tricuspid regurg demonstrating suprasystemic pulmonary pressures. We see the IV septum flat, in fact, bulging into the left at end systole, and leaving the LV not a whole lot of room to pump blood out. And mind you, we have made things worse by cranking up the mean airway pressure a fair bit. The RV seems to be struggling to pump blood out with quite a low TAPC, suggesting that there is significantly elevated pulmonary vascular resistance. So now that we have tried to support the LV and we have clear evidence of elevated PVR with a baby who's clearly hypoxemic and not moving, and I dare say kind of moving towards dying, nitric here may be a lifesaver. Only if used judiciously. So Dr. RCT here starts nitric at around 5 parts per million. And this is what the echo shows in a couple of hours. Now, things don't magically improve. I know we come to presentations and we see these stories where things magically improve in an hour, but in the real life, that never happens. But what we see in a couple of hours is slow but steady trend towards some improvement. Yes, there is still elevated PVR, as evidenced by the tricuspid regurg, but now we see the duct starting to shunt a bit left to right. It's more bidirectional. The septum looks a little bit more rounded. The LV has a little bit more breathing space. The RV function looks a little bit better. So, as evidenced by a slightly better TAPC, your LV function looks preserved. And from a clinical perspective, we find that the oxygen requirements have slowly come down to 55%, and your systolic blood pressures have improved. Not surprising, because your LV seems to have more volume and is functioning a little bit better. So what has happened slowly is that the baby has come off the edge from literally dying from hypoxic respiratory failure, but it's still not out of the woods. And that's why if you choose to use nitric following pulmonary hemorrhage, there are some considerations that you have to keep in mind. One, do not leave the bedside, because the physiology can rapidly change. In in a matter of a couple of hours. Use other measures first, like supportive measures. Optimize your ventilation. Ensure that your left ventricle is well supported, something that is not talked about and not appreciated as much as it should, especially in these smallest babies. And therefore, serial clinical and TNA assessments is the key to precision management here. And if you choose to start nitric, what we have suggested in our recent position statement from the Canadian Pediatric Society is start at a low dose at 5 to 10. I know that's not based on strong evidence, but based on some of the trials that were done in small babies, and be very prompt with weaning your nitric when you see a response because of that rapidly changing physiology. Because physiology can very quickly, in a matter of hours, go from this, where you have this big duct, which is mostly shunting right to left, with a dilated right ventricle that is struggling to pump blood into the pulmonary circuit, to this, where you still have this huge duct, which is now started to shunt almost purely left to right. So if you leave this baby and walk away and come back in 6 hours in the morning, you might find the baby with worse pulmonary hemorrhage and hypotensive. So talking about hypotension, that kind of brings us to the last part of the discussion, is how to choose the right inotrope or vasopressor. And as I've mentioned a number of times in the talk, there are a number of different agents with varying effects on your pulmonary vascular circuit and your systemic vascular circuit. So it is important to carefully choose the right agent so that you don't harm the patient. And that's where serial neonatal echoes might actually be helpful. For example, if you have a clear elevated PVR physiology, yes, pulmonary vasodilators such as nitric and dobutamine would be helpful. But what if your LV is not functioning well at all? Then what do you choose? Do you choose dobutamine? Do you choose epinephrine? Because if you choose epinephrine, then that has an adverse effect on the pulmonary vascular circuit, and that might worsen your PVR. So that's where the choice really depends on the degree of myocardial compromise that you need to figure out through your echocardiogram. If your LV function is moderately decreased, then you choose something that is easier on the pulmonary vascular circuit, such as dobutamine. But if your LV is really struggling, then you are left with no option but to use epinephrine, because otherwise your systemic perfusion and your end organ perfusion will be severely compromised, leading to irreversible end organ damage. So to summarize, what did Dr. RCT do in this situation? He started off with instituting careful monitoring, good nursing care, which is, say, the most important out of all that he would have done for this baby, optimizing ventilation, but not overdoing the mean airway pressure, considering surfactant if the baby remains persistently hypoxemic after the bleeding has subsided, using blood products as required, considering endotracheal epinephrine if there is an uncontrolled bleeding. And when it comes to the role of inhaled nitric oxide, taking into account the following. One, he did not use nitric as a first-line therapy, which was probably a smart thing to do. When did he consider nitric? When the baby remained persistently and severely hypoxemic, and there was clear signs on the echo of elevated PVR, such as right to left or predominantly bidirectional or atrial level shunt, with a flattened or bulging septum in end systole. And when to refrain or move away from nitric? When the physiology has switched to a predominantly flow-mediated or post-capillary phenotype, such as when you find a large, predominantly left to right ductal shunt with left-sided volume overload, or you clearly have evidence of LV dysfunction where your first job is to support the LV function before you consider anything else. And while you're doing that, you have to tailor the choice of inotrope based on the degree of myocardial compromise, and that's where, again, echocardiogram will help guide your choice. So coming back to the question that we started off, did Dr. RCT, who loves practicing evidence-based medicine, end up practicing evidence-based medicine here? I would argue that yes, he did. Because he started off with the right things. He started off looking for the relevant scientific evidence. But soon he realized that in this situation, there's hardly any good quality, high quality trial evidence to guide his decision making. So that's where he sought Dr. EBM's help to guide him clinically step by step. And the two together, they weighed the pros and cons of each and every therapy in terms of how it affects the outcomes that actually matter to families, that is death and bleeding in the brain. And therefore, by combining these three principles, he actually ended up conforming to the basic principles of practice of evidence-based medicine. So I'll just stop here and I'll be happy to take any questions. Thank you.
Thanks, Souvik. That was an awesome case-based discussion on this, pulmonary hemorrhage, which is indeed for us, for everybody who works with these children, a quite sort of terrifying event. You went to the physiology of pulmonary hemorrhage, the assessment in different phases, which I really liked, and then the treatments, which was basically a sequence of treatments. It's not all at once, but you have to figure out which treatment is timed appropriately. I guess I really love that end slide where you said that there is evidence-based medicine, but in rare diseases, of course, you're never going to have a big trial. Although, hey, we do absolutely need more trials, maybe more on prevention than anything else in this particular. And then you described, of course, the clinician, what they know and what they had to know about.
Yeah, I can hear you.
Okay, because my whole picture. You talked about the physiology and what we're supposed to know, and we need more detailed description of these babies. So I still think retrospective is good. Brett Manley just said, we got 95 patients with a...
I think I just lost you there.
So, hi, Souvik, it's Julie.
Hi.
Can you hear me? Hi, I'll
Yes.
take over while Kurt is offline. So we've got some questions here from the chat pane. So Brett's asked whether there's any worth doing baselines, coax, and with a pulmonary hemorrhage. I guess that takes quite a long time for you to get your coax back, right? Don't know what happens in Melbourne, Brett. 5 seconds.
Well, I mean, it's a fair point. If you have an arterial access, then it's fairly easy to send one off. And again, I know that having worked in a number of different centers, I can attest that the turnaround time varies, depends on the time of the day and night and weekend. And therefore, depending on where you are working, it may or may not be helpful. But it may be helpful if you have an arterial access, you can send it off quickly and you can have a quick turnaround time. It may help to kind of make a decision on some of the other like transfusion support. Like, do you use FFP? Do you use cryoprecipitate? I think I would just go ahead and give an additional dose of vitamin K regardless. It doesn't really harm. But transfusions, we know that like massive transfusions have their own downsides. And we know like from the trials, what we know is that more transfusions are not necessarily beneficial. In fact, from the platelet trials, we know that it might be harmful, but we don't know a whole lot about what happens in these very, very sick babies with active bleeding. So we cannot just go gung-ho on transfusions. We have to take this, like consider these therapies carefully as well. And that's where I think coag profile might be helpful.
That's true. The Cheryl Rogerson from Melbourne does say that how often is an underlying coagulopathy a cause of the hemorrhage, right? It could be a secondary effect.
Yeah. And you're right that it might not be a cause to begin with, but it could be a potentiating factor once the baby is in a massive hemorrhage, because that's where the consumption sets in, and then you're down this spiral.
Yeah,
That's
I don't think we can.
Could be helpful.
Yeah, true. I don't think we can leave without answering this very important question, though. So if you scroll up your chat pane, you can see from Dr. Rathmoni Hing, right? What happens if you don't have nitric oxide? And I think many parts of the world don't have nitric oxide. And Dr. Rohit says, any role for sildenafil?
Yes, good question. It is a challenge to manage a baby with like who's in severe like you have a clearly elevated PVR physiology, and if you don't have nitric, I honestly do not know whether sildenafil in that short period of time would have the same effect as nitric. We need like some evidence. I don't know if there is any evidence, if anyone is aware of any evidence. I'm not aware of any evidence to suggest that in a baby who's acutely unwell following pulmonary hemorrhage with an elevated PVR physiology, sildenafil could replace nitric. I'm not sure. I'm willing to learn from others if they have any insight on that.
So for the audience, if you have any experience of that, please type on the chat pane if you're shy, or you can just unmask yourself and tell us about your experience. So anyone, just interrupt anytime. But in the meantime, we might go to Sam from Singapore. He's got a question here. Souvik is a few boxes up. He says, okay, large PDA, left to right shunt, could IV Indesit have been considered, which might have prevented a massive PH?
Yes, if you look at Martin Klucko's old trial that was stopped early, there was evidence that pulmonary hemorrhage was lower with early use of IV Indesit. So yes, there is some evidence that could have been prevented. We recently concluded our trial on selective early treatment of the PDA, the SMART PDA trial, which we are writing up right now. It was a multi-center trial that where we exclusively enrolled less than 26 weekers. And we found that there was quite a sizable difference in the incidence of pulmonary hemorrhage, which aligns with what Dr. Klucko had found a few years back. So yes, early shunt modulation with drugs may have an effect on this very, very important outcome.
Okay, Indesit. Okay, back again. So maybe we might go on. Targeted, yes, not for everyone. That's naughty. And I guess milrinone, a systemic agent, would that be helpful? That would be a bit of a big one.
Yeah, milrinone, again, it's probably personal experience. I'll let others chime in as well. It's a bit of a double-edged sword, especially when you're using nitric. I've found that in small babies, sometimes you drop your, you end up hypotensive, and that may not help the cause in some situations. So you give milrinone with the hopes that, yes, it will improve contractility, but you end up more hypotensive. And then you are bolusing, which is not really helping if you have some degree of RV dysfunction. So it ends up being a mess. So I personally stay away from milrinone. But again, I don't know if other centers routinely use milrinone in this situation.
Okay, I might pass you back on to Kurt now that he's come alive again. And if I'll see you next week in Tokyo, Souvik.
Yes,
Have a safe trip. All right.
Yes,
okay, over to you, Kurt.
Nick just mentioned in his experience with milrinone, it actually tended to open up the PDA, so probably wouldn't help in these particular scenarios. I have a question, though, which is related to the PDA and the overcirculation. Sure. Half of these babies did not have a PDA. Can you explain that?
Sorry, come again?
Half of the babies who develop a pulmonary hemorrhage actually didn't have a PDA.
Yeah, so PDA is, as I said, that's one of the mechanisms. But one of the other mechanisms is that we have for long underappreciated the left side of the heart, especially in small babies, and its impact on the physiology. We are now starting to uncover the whole area of LV diastolic dysfunction in small babies and its association with congestion on the pulmonary venous side and its effect on pulmonary hemorrhage. So maybe as we explore more and interrogate more on the left side of the heart, maybe we'll try and find the answers to why pulmonary hemorrhage happened in those babies where there was no duct, but still the babies ended up with a pulmonary hemorrhage.
Did you find this same thing in your SMART trial?
We have not explored the LV function. So we have not collated the LV function data from all the centers yet, because that was not an outcome in the trial. So that would not be featured in the primary publication, but that's definitely one of our sub-studies that we are planning. Because we do want to explore that in more detail.
Yeah, and this is happening a lot, isn't it? We have a main trial where we do a specific question with a very specific answer and hypothesis, and actually we collect a lot of information which are not presented in the main trial and then have to be presented in other sort of bits and pieces. But for some scenarios, I find that information is way more helpful to the clinician than the main question. Nick, you want to tell us a little bit more about that milrinone experience you had? And you said it's not experience, it was the trial. Can you tell us a little bit more about that, Nick, if you want to, and available? Nick, are you available to speak?
Not sure. Can you hear me?
Oh, yeah.
Hi. No, this was the prophylactic milrinone study where we were looking to try and see if milrinone would reduce the incidence of early low systemic blood flow, and it didn't make any difference. But one of the adverse effects we found, because we had a group of babies that got milrinone and a group of babies that got placebo in a double-blind manner, was that in fact the placebo group, the duct tended to do what you expect, which is it got smaller, whereas the milrinone group, it actually stayed the same or got bigger. So I think milrinone may well have a direct effect on the ductus actually in maintaining it. So you would think physiologically, I'm not even really sure. I'm sorry, I've missed most of the talks. I apologize for being late, but I'm not sure that we really know what effect milrinone has on the pulmonary circulation either. I think what we know is mostly about what it does on the systemic side, and it dilates, which, as somebody quite rightly said, can cause hypotension.
Yeah, and I thought that the trial also showed that actually blood flows did go up overall in specific populations on prophylactic milrinone. Is that correct, Nick?
Well, we weren't looking to treat low systemic blood flow. We were looking to prevent it.
Yeah.
And so we can't really comment on the data was not collected in a form that allowed us to, because the natural history of blood flow over the first 6 to 12 hours, it tends to fall away and then improve. We couldn't see a difference between the two groups.
Yeah.
This is the study that Mary did.
So, Souvik, you discussed nitric oxide and when to target it and be specific, and you started a low dose. Do you ever do it like really short? You give it for 10, 15 minutes, and if it doesn't work, you stop it? Or you will always, if you start it, continue it on for several hours?
Yeah, so if we will start with the low dose, again, acknowledging that evidence for that is limited, but we are also cognizant of the fact that if the physiology rapidly shifts, there could be harmful effects, and therefore we would start low. If there is no effect, but we have documented and we're fairly certain of an elevated PVR physiology, would actually go up higher and give it a good try. So up to 20 before we say that, okay, it's not helping. Maybe there's something else that is going on that we have missed in the echo. Let's repeat the echo, and we would stop it then, but not without a good try.
Yeah. And so your targeting of any of these cardiovascular medications is hugely driven by doing cardiac ultrasounds. How do we get a service in our hospital to make that happen?
That's a whole different 1 hour discussion altogether. But I think the training programs, I mean, like your, like in Australia, I mean, I think it all concurrently started there, and also here in Toronto with Patrick. So I think you are well ahead of some of the other countries in terms of getting a training program going. But what we have done here is try to formalize the training. So now we have our training program, a 1-year training program accredited by the Royal College. So fellows have an option to apply for a 3rd year of fellowship with dedicated training in neonatal hemodynamics. And usually once you graduate with an additional recognition from Royal College in neonatal hemodynamics, your chance of getting a job is higher. And also centers want to hire you to expand that service. So that's how what we are seeing in Canada is a lot of centers who have expanded their hemodynamic service by slowly recruiting these physicians who have completed their fellowship and have done an additional year training in an accredited program. And by one by one, like in our center, we were 1, now we are 3. We are a lot better than where we were 2 years back, but still, we still have gaps in our service in terms of holidays and weekends. So the hope is get to 5 or 6, and then we can kind of have a 24/7 coverage. So that's how you slowly build your center's expertise in terms of.
I think it's really important to get the colleges involved and make everybody realize that, particularly at the trickiest moments, severe hypoxia, your patient almost dying, how much extra information we can gather from having information about the physiology, particularly the cardiovascular information. Look, so it's 2 o'clock, and this was an awesome talk. I really like the combination of the EBM and the Dr. RCT versus, the physiology and how to apply that in an individual pace right then and there. It remains tricky. Thank you so much for this presentation. It is recorded, so we'll send the link out after we reviewed everything. And thank you again, and I hope to speak to you soon.
Perfect. Thank you so much for having me. Thank you.
Okay, no problem. Thank you.